Well, good morning. I welcome everybody to talk about this paper that was recently published in the Journal of the Neurodiagnostic Journal, a prospective look at the prevalence of setup electrode swap errors across 450 intraoperative neuromonitoring cases by Alan Mandir, Chiara Evinger, Lauren DeBruyn, and Crystal Kenny. And we have today Chiara Evinger and Alan Mandy are here to discuss this. So, I'd like first maybe Alan to tell us a little bit about yourself.
Great. So I'm Alan Mander. I started my training back in undergrad as an electrical engineer, and that kind of drove me to enter an MD PhD program in neurophysiology at Emory University. So I followed it up with my residency and fellowship training in neurology and movement disorders, as well as neurophysiology at Johns Hopkins. I took that combined interest from my graduate and undergraduate and clinical training that led me into the OR at that time to perform pallidotomies and thalamotomies, which later evolved, of course, into DBS implantations. But while in the OR, I was exposed to the other modalities of intraoperative neuromonitoring, and this all appealed to my background. So I made the decision pretty early on to exclusively dedicate my clinical practice to intraoperative neuromonitoring. And I've spent the greater percentage of my career mainly in the OR than outside remotely, but have done both in big proportions for more than 2 decades now. And I recently moved away from the academic positions that I was in to continue to do full-time work in IOM, but all in a remote capacity with real-time neuromonitoring associates, where I am now.
Great, thank you. Chiara, do you want to tell us a little about yourself?
Sure. So I obtained my PhD from Vanderbilt University School of Medicine. I have been in the field of IOM for almost 25 years. Currently, I work in physician quality for real-time neuromonitoring associates. In a previous life, worked for a cochlear implant manufacturer. And that is what supporting those devices was what took me into surgery and kind of introduced me to intraoperative monitoring in the first place. At that time, I thought, well, wouldn't it be amazing if this OR thing could be a full-time job? And turns out it is. So that's kind of how I got introduced to the OR, fell in love with it, of course, right away. And been here for almost 25 years.
That's wonderful. Okay, well, I'd love to have you summarize a little bit of the paper, a little bit of the introduction of what brought you to discuss electrode swap errors, a little bit about the methodology results of discussion. So either of you can pick up, or maybe some of you want to do some parts and some want to do other parts.
Sure, I'm happy to start. I think with our experience and anyone who works in the OR, we would agree that it's a demanding environment, and the setting up in the OR is a demanding task. There's these time pressures and the overall demanding OR environment in general that just leads to these type of intense periods of time, especially during setup in the beginning of the case. And depending on that surgical case that may be there for the day, you could be placing over 50 electrodes on the patient and then have to further connect those correctly to the IOM equipment. So all these conditions with the pressures and the amount of tasks one has to do just presents the opportunity for potential errors in the placement or assignment of these electrodes, and we call these electrode-swap errors, and that's where we came up with that term. And these are not trivial potential consequences, right? So surgeons can be given incorrect information if those errors exist, and at times cases of false negatives have been reported in the literature with actually morbid surgical outcomes, which include paralysis. So if you take all that together and realize that errant neuromonitoring can also have more wide-ranging negative effects because it just devalues the field of neuromonitoring itself and maybe contributing to these these wide ranges that we see of any one specific modality of sensitivities and specificities, it became, something that we felt this might be an important thing to pursue. Furthermore, if you look at the amount of cases that are done, so there's over 800,000 IOM cases that are monitored just in the US alone annually. So even a very small percentage of errors exist that may equate to a fairly large and significant absolute number. And we hadn't found anything prior in the publication literature that actually looked at the typical IOM setup and what kind of error prevalence existed. So we went ahead and prospectively analyzed a set of our cases to see what we would find. And so that's what we did. We took a section of time, 6-month period, and we examined the sequential cases where I, as the only board-certified overseer, was involved in this to be consistent with detecting these errors. And I have the experience over 20 years to feel competent in doing that. And we declared a case to have an electrode-swap error if it met several conditions. One, the in-room surgical neurophysiologist had to not recognize that swap. And two, the surgical neurophysiologist had to agree after it was pointed out that a swap was present, and then they additionally had to find the exact swap and fix it correctly. So with all that done, we took those data, and then Kara, who holds a CNM and a PhD, as well as Lauren and Crystal, who hold CMs, went through all those data again and made sure that each of those that were flagged and determined to be electrode swap truly were, that they were found and fixed correctly. And so with all that, we took those data and found the prevalence of 5.6% of electrode swaps that were found across all types of cases. And these cases were typical for what I would see as remote neuromonitoring. They're mainly orthopedic type of spine procedures, but also a good amount of cortical procedures and a small amount of probably peripheral nerve and ENT type of procedures. But notably, things like an aneurysm case, which we found had a swap in stimulating electrodes in the upper limbs, and several tumor cases in the brain and in the spine where recording electrodes were swapped. Now, I think what is important as well is that as the remote neuromonitoring overseer, I discovered these swaps only by looking at the data on the system, right? So I wasn't in the room during these times. So all these could be found without witnessing the patient itself as a first step. And so you can use methods to detect these swaps by examining just the data you see, looking at the morphology and the latencies of evoked potentials, looking at recruitment patterns and or physiological artifacts on the on-screen data all together. And then maybe also to correlate, if it's pertinent, to known pre-existing pathophysiology, allows you to say, hey, this is a suspected swap. We think this is present, and we think it exists here. Please check these electrodes, see if that's correct. And if that was the case, it's electrode swap. So I think some of the take-home points were that we did find that the majority of swap errors, which were on the recording side, were found, but also some stimulating electrode swaps as well. And then even a double swap, meaning that both electrodes on the stimulating side and recording side were found, which are generally more difficult to find. And then more than half of those electrode swap errors were committed when the primary technologist was non-CNM certified. That doesn't mean there wasn't a CNM certified in the room with that person, but if the primary sign technician was non-CNM, that was categorized as itself. And overall, more cases were done by CNM certified technicians as primary. So that percentage of being higher in non-CNM becomes even more significant because of the ratio of what we had seen. So overall, if you look at the potential consequences of electrode-swap errors, which we know are grave, as well as the volume of those cases that we're talking about that are performed in standard practice, we felt this is a significant prevalence. And we also showed that you can detect these errors early on in a case without having to even look at the patient. You could do that on your screen, sitting down, analyzing the data yourself. And that allows the opportunity to efficiently correct these inevitable swap errors that are going to occur because of the oral environment. And the advantages that come from this are avoiding that misinformation that is given to this operating surgeon, and also extra benefits. I mean, a corrected swap usually results in an increased signal to noise immediately in certain modalities. So you already have an increase in your sensitivity and specificity in your test alone.
Well, this is great. You know, the thing is, for me, that's a huge number of errors. 5% is massive. Now, I wondered, of that 5%, how many times did you say, I think that there's a swap, but there wasn't? Was that a much higher number? I mean, I know it's not in the paper. What was your
Yeah.
expectation?
Now, I think it's an excellent question because it's not something I've flagged and quantitated, but clearly, empirically, that happens, right? And the results of that can be one of two things. There really could be a swap, and it just never is found, right? So we can say, boy, that really looks like a swap. Everything points to a swap, and the in-room surgical neurophysiologist says, well, I don't see it. And the reasons for that could be severalfold. One, they may not be able to access the electrode. Some of them will look at the pod, oh, it's correctly hooked up to the machine, but can't trace those wires back to the patient, whether they can't get under the drapes or difficult to see, or there's just a mistaken where the limb is because the patient's been flipped and turned and whatnot. The other thing could be that there is no swap, right? That it just looks suspicious. And that can happen when the data is just poor in general. I said, boy, there's poor data here. I can't really make out these waveforms. Let's go ahead and check that there's a swap. So I think that happens overall a lesser percentage than the 5.6% that report, but it certainly does happen.
Now, the other question I had was the issue about the CNM tech. So, well, you sort of mentioned that really when a non-CNM tech was there, it was really with a CNM tech most of the time, who was maybe their supervisor, their trainer, or something like that. Was that the situation for most of those?
Karen, do you want to answer that? I can answer that if not.
Sure. I mean, one thing I would say is we don't always know if there's someone in the background helping that may not be necessarily named in the chat or something like that. So sometimes, you know, there may have been some assistance in the background that we didn't necessarily know about or weren't aware of always. Did you have something to add, Ellen?
I think that's exactly right. So we can't know for sure, nor can we know precisely how helpful is that CNM when there, right? So the
Yeah.
CNM could be there just kind of sitting back and watching, or it could be actually assisting with electrodes and things like that. So at minimum, they're more helpful than being absent, right? So it kind of makes some of those errors kind of suspicious also for the CNM certified technicians as well, which we know happens in CNM. We had some cases that were primary CNM and there were swaps. So that exists as well. But I do usually get some notification that, hey, I'm here. I'm also here with SNP X, and he or she is there, and I know that also CNM. So I think there's a good percentage that do have CNMs there as well in some capacity.
So part of the question is some of this related to the fact that they're doing education and other time is spent in sort of teaching that takes away a little time from double checking? Is
Yeah.
it due to experience because a non-CNM tech may have less experience? Or is it due to educational stuff? And you may not be able to have an answer to that question, but I wondered what your thoughts were on, where that comes from and, what type of training that you feel would help prevent these?
I could take that one. Um, I, the difference between the CNIMs and non-CNIMs. So there may or may not be knowledge gaps, but most of the time there are experience gaps between the two. So a non-CNIM might not feel as comfortable in the OR overall. They may not have had as much exposure to the high pressure environment. Um, they may be under increased cognitive strain when they're setting up due to, perhaps lack of familiarity or less exposure to the stressful environment. Um, and Also, certification, I think, um, sort of teaches people how to be systematic in identifying errors, systematic in applying electrodes, developing, um, standard protocols. Also, I think CNIMs tend to have better access to formal policies and procedures, which can be very helpful also in these environments.
And I would agree with all of that. And I think the other piece of that may be, and as Kara so rightly points out, what are your experiences? What are your focuses in your training? Have you been paying attention to these things? I mean, those who were CNIM certified and had electrode swap errors that we found had at least 8 years of experience in their toll. So it wasn't a brand new CNIM person that came out there. And the question is, again, swap errors will occur. It's, how embedded are you and how ingrained is it into you to check your setup to say, hey, this looks right. And I think there's a lot of little factors that go in there, which I think to sort this out makes it more confusing because I think to power a study of that becomes large. But it depends. What montages are you using? What is your tech company using as a standard SCP montage? And what do you look for? What is the version of your machine, right? Some of those software versions are more confusing than others, right? Some of them show that when a channel is electronically inverted, it shows up on the screen. Others, I have to go through and look at that. So I think it's very multifactorial, but in the general senses, and I think also supported by the overall numbers that we have, is that experience is a big key here.
And I think the numbers maybe belie the truth just a little bit if you look at it in terms of, on a per case basis. It was slightly over 50% with non-CNIMs, but the non-CNIMs had errors in roughly 1 in 12 cases, while the CNIMs had errors in roughly 1 in 28 cases. So if you look at it that way, that's a significant difference.
Did you guys change your policy manuals after you came across this? Did you add anything for the technologist or for the supervising physician to do differently once you found this?
So some of the first steps that we've done, and Kara headed up a presentation to a certain tech group that we both were on that to try to kind of point out these type of things. So I think that may be one of the very effective things to do. I myself went to a annual meeting for a different tech group and gave a talk specifically on this paper to kind of bring this out in knowledge. And the change anecdotally, and this is all anecdotal because we haven't done anything systematically about this, was very remarkable because the week after that presentation to that tech group, I had a tech come back to me and say, oh, I found the swap. Here it is. And this was actually fairly new technologist in the field, and I was very happy, and of course made me very happy too to see that. And the feedback was been very positive. So I think those kind of things to do might be the might be an effective way of approaching this. And I do think we can sit down and look at kind of the policies that or methods that we put in the paper to kind of pass that around to everybody to see if that would make a difference. I think we all have different approaches to things, which is one of the reasons why I didn't want to muddy the picture with more than one overseeing neurologist on this paper here, so to be consistent. But I think we all kind of head towards that same goal. But I will say it is different between any two oversight neurologists as well, and also depends on our experience and kind of focuses as well.
It'd be interesting to find out for the next paper if, without really changing policies and procedures, but making people just aware of the issue, has changed the practice.
Yeah.
Because that would be really interesting
Yeah.
if that was just enough to
Yeah.
keep people interested and get them motivated to do an even more careful job. So that could be really interesting to see exactly what happens there. That would be great. Good. What about let's see, we talked before about the troubleshooting rules that you used. They were just outlines of what you typically used. They evoke potential, polarity, where the electrodes are, all that, the artifacts and things. Which of those, it's not in the paper, do you think was most useful? Now, I know it's not there, so you may not have studied it. But when you brought these things up, you probably have it in the back of your mind somewhere that this is sort of the thing I look at first to find an electrode swap. What do you think?
For me, I think it starts with looking at SSEP. The easiest one is SSEPs. If you just evaluate the phase and the latency in particular, the phase can tell you a lot. If something appears inverted, it probably is. You should expect when you stimulate, for example, the left upper extremity, you should expect a response over the right hand homunculus cortical area. If you're not seeing that, that can be an indication. Latency is a big one. Obviously, it takes longer to get from the head to the ankles than it does from the head to the wrist. So the upper extremity SSEPs will always come in earlier in latency than the lowers. And that's true with MEPs as well. So just checking your latencies can tip you off to a lot.
I absolutely agree. I think in my head, the SCPs are the go-to kind of, sine qua non of, this is truly a swap. But I could get tipped off, if there's no train of four that's showing up, and especially if I can convince the S&P to run free run EMG while they're running train of four, right? That's an immediate detection of a swap, right? So those are very nice things to do. And again, I think it goes to your point. If you can kind of make them aware and kind of show them, hey, if you just turn on your free run EMG as you're running your train of four, boy, we're ahead of the game already. So I think that kind of education might get there. But without question, having the SCP morphology and latencies, as Kara so rightly points out, is such a powerful tool to say, hey, this is wrong. And in fact, the most common swap that we found was C3, C4 at the scalp because of SCPs. Very difficult to find that in an EEG, right? Unless you have some known pre-existing pathophysiology, but both are affected on that swap. And you would pick it up mainly because of SCPs.
And on the topic of pathophysiology, that's another tip-off. If you have a patient with, say, a left foot drop, and you have an asymmetry in your lower extremity SSEPs, where, the left is better than the right, that should be a tip-off right there. The responses should match the pathology. So always watch for, asymmetries that may reflect or reflect the opposite, either way, of a patient's pathophysiology.
Now, a lot of people have talked about things like pre-labeled electrodes, electrodes in ribbons, color coding things. Do you use those tools? Do you not use those tools? What do you think is the most useful at preventing those, of those kinds of things, labels, color coding, and things like that help?
Personally, I feel like color coding is a big help. If you and really, it doesn't matter what color you assign to what, as long as you as an individual technologist or neurophysiologist know what your rules are, right? So a lot of people use blue for left and red for right. A lot of people may use, the old adage, blue eyes, red lips for facial nerve monitoring. So sometimes the colors can be really helpful. Don't let them get in your way. Use them to your advantage. You can bundle electrodes that go on the same side of the patient. There's a lot of things you can do with the colored electrodes that can really work to your advantage.
And it's something that we typically used throughout any institution I was at. And I would even stress the importance of trying to be consistent amongst different S&Ps, because one takes over for the other, right? If you use a different system, you're not going to be there. So that means labeling the headset the same, labeling the colors that use the same as consistently as possible. So even if you passed off a case, even then the oversight neurologist may say, hey, can you check this? And this way they're checking the right thing and not giving the wrong information either.
I think that's a very, very good point, Dr. Mander, that if you do something that's not standard, have a protocol. Do it the same way every single time. And particularly in the case of like a handoff, if someone else needs to come in to the OR and give you a break or something, they need to be able to know very quickly what you've done and how you've set up the patient. So by sticking to the same way every time and being consistent across technologists too, as Dr. Mander mentioned, very, very important.
So do you actually, this is an interesting question. Do you actually tell people that they must do it a certain way, or do you let them decide, this is the best way for me, I've done this for years, I always use this method of checking myself? What's your ideas on that?
Yeah, it's hard to impose something that's not natural to somebody. So I'm very flexible as long as there's some logic in that approach, right? Because when I set up electrodes, it may not even be the best way of doing it compared to others. And certainly I've been proven in the OR, there are other people better than me in putting electrodes on and sticking them in the right spot. So as long as there is a system in place that makes sense and that they can pass that off well, then that is up to the preference of the surgical neurophysiologist. And I think it's important for them to feel that they have that control, because they're going to know what works best for them.
See, that's a really interesting point. I don't think everybody does that. And I think that could be an interesting idea, because I think a lot of places would say, you do exactly this thing every time, but that may not be the best thing. It's
Right.
like what you said, if people use what's natural to them and what
Right.
they've done for 20 years, especially people who move from one company to another company to
Yeah.
another company over years, that person has 20 years of doing one thing.
Yeah.
To come to you and then change it won't be the best for the patient. So
Yeah.
I like your idea to let people use what's best. I think that's interesting and a good idea.
Right.
But I would
And each surgeon is a little different. Their demands are different. What they're allowing you to access. I mean, I'm not going to know that remotely, for one. And that person in the room is going to have the eyes and ears better to address those questions.
Do you think that in your experience with all this, did any of them have a clinical effect? Any of these swaps, these errors, did they have a clinical effect?
So in this study, no, and I think almost by design, right? It had to all be fixed, right? Found and fixed, and they all were. So there was nothing, and even throughout that period, there was nothing. I think if I had come across at any point, I suspected electrode swap, and this is what I would do, and this is what I do do. If I still have a strong suspicion, even though it's not verified. I'll note that, and I'll discuss that with the in-room S&B to say, yeah, maybe it's a lumbar case, and the left arm and right arm might seem switch. If we have a drop in one arm, we're going to check both arms, right? We're not going to just say, oh, it's the left arm, and futilely kind of address the wrong arm. We're going to say, there might be a swap here. It's suspicious of that, so we're going to take that account. If there's EMG fine on one side and we think it's a swap, we're going to tell the surgeon, that may not be specific. We'd have to get under the drapes to really check that out, just to be sure. So I don't have an experience myself with that, but clearly the literature shows that, and shows, what Chiara is showing, latency's difference being so obvious, and then you lose the, quote unquote, lowers on a scoliosis case in motors. Patient wakes up paralyzed because you called that was, it just, those kind of mistakes can lead to really serious consequences.
What do you think the total error rate is? I was looking around and I found this recent paper from Germany that I sent along to you that's a little bit hard to understand and confusing. But if you work very hard at it, it seems that this is for monitoring thyroid surgery, that the total error rate included very minor things like labeling things incorrectly. I was up to 60% in any case.
Yeah.
I'm sure that's a little higher than any of us would think would be generally acceptable. But what do you think that the true error rate is, including swaps? But what other kinds of errors do you see happen?
Yeah. Well, that was the University of Mass, and that is a strange paper, right? So it looks at a technique that we don't yet really use widely here, which is actually not a bad technique, which they actually stimulate the vagus nerve directly and then record continuously. A very, very clever way of doing things, and probably very helpful in thyroid and parathyroid surgeries. But there's no mention in that paper of who is doing the monitoring, right? We don't know if there's a senior tip. We don't know if it's a representative from the company. We don't know if it's a surgeon trying to do it. So that 60% is really high. And I also don't know the clinical, as you suggest, what is the clinical outcome of those cases, even though they're misplaced. It's difficult. But there are plenty of opportunities for errors in the OR, right? And so, and that paper does point out that there are kind of inherent mistakes in some of these systems that they used, right? And so, on occasion we find kind of these errors in the machines, we report it to the company and make an FDA kind of report as well. When those errors arise, it's a very small percentage in that case. But if you take, things that are, common, like pedicle screw stimulation, right? Very easy to have errors there, right? And that could be because the patient has a neuropathy or radiculopathy. It can be because of the type of the composition of the screws that are used. It can be used because it's minimally invasive and, there's current shunting and whatnot. So, all those type of things, or in one case we had the screws were touching. So, you get shunting because it's such a poor placement, perhaps is a reason why you get such a high threshold. So I think we have a lot of things that can lead us to errors. Fortunately, I think our overall false negative rate remains low, and I think that is a testament to the alertness that we have and the wonderful SCPs that we have and the great oversight neurologists that provide these type of services. But we're not immune from it. That's for sure.
Right. Were there other things that you had that you wanted to talk about a little bit? One question that was here is an interesting one. What about positioning? Because that makes everything more difficult. Was it different with prone, supine, on the side?
Well, positioning can be a major factor. I mean, we'll just be honest. Positioning, sometimes you can lose your landmarks that you use for left, right, especially repositioning. If there's, say, pre and post flip baselines, if you have to reinsert everything, the first electrode insertion is rushed enough. But if you have that kind of situation where there's a pre and post flip, or just a repositioning, uh, prone to lateral, or whatever the case may be, repositioning can be even more challenging because the time constraints are even, the pressure's even higher. Everybody's kind of waiting for you. So that, repositioning can be very challenging. And like I said, especially if there's multiple repositionings or a double flip, things like that, you can really lose orientation easily, especially once the patient is draped. So positioning is a really large factor in these, although I don't believe we found a difference in positions, numbers of repositionings relative to errors, which is surprising because you would think that every time you reposition, you're opening yourself up for more errors.
Right. And we definitely thought that was going to be the case coming in, but I think we quickly realized that the study is underpowered to answer that type of question, right? So,
Right.
and we did try to look at, just one flip or multiple flips during the case, does that increase? And I think it's something that anecdotally we see and would expect, but we didn't have the numbers to do that. So nothing reached significance on that report.
Right.
Whether you're doing initial positioning, initial application of electrodes, or repositioning, there's an urgency to maintain the best efficiency possible. And sometimes that conflicts with the need for meticulous attention to detail that really is required for accurate setup. So those can be two opposing forces that really can have an impact.
Okay. Well, I wondered if you have any final thoughts for technologists that might be getting started in IOM and learning a little bit about things. What your general suggestions are for them.
Right. I had the wonderful pleasure of maybe training hundreds of different, technologies over there. There is a pattern that seems to hold true, right? You walk into the OR, if it's new to you, you are a deer in headlights, and everything is nerve-wracking, everything is overwhelming, but you get over that, and which is a great thing. The bad thing is you get over that very well, and you get to a level of overconfidence. And this is just a repeated pattern that we see. And I try to tell everyone I encountered that this is going to happen, right? That you're going to be too nervous, overconfident, and then you're going to be an excellent SMP, right? But be humble until you get to that latter stage, because we don't know what we don't know until we know enough. And so I think that is a good message. I'm humbled every day, right? And I try to keep that with me, because this, as we talk about, is a very daunting field. And I know all my years in the OR how extra daunting it is once you're in there under those specific pressures as well. So allow us to help you, right? I'm sitting back, maybe in a more calm position with a lot of experience. I can help, right? If I point out something, there's a reason I'm pointing it out. And I think that it's worthwhile checking. So let's work together. We'll communicate well. And, either don't be too nervous or too overconfident, and we'll work together and get this out.
I think consistency is a big factor as well. Be consistent. Do it the same way every single time. If you need your routine, stick with your routine. If you need to wait a minute for, the circulator to place a Foley or something because this is the order you do it in. If that's what you have to do, then do it. Just be consistent and double check, triple check, quadruple check yourself. Check your setups. Look at your waveforms. If they're inverted or appear to be inverted, by all means, don't just go into the software and check the invert box. That will solve your immediate problem, but it would actually create bigger problems for you. And potentially you're still in a situation where you could miss something. There's a particularly good example of that in the paper, where even if you just invert SSEPs, let's say, some of those electrodes that you may be using for EEG, still are not inverted, so you still could miss something. So don't just invert. Get up, check your electrodes, check them at the patient and at the pod always. And if something doesn't look right, it's probably not.
I think one of the things you both hinted at a little bit was to have the confidence to say, wait a second, I think I need an extra minute to double check it before you finish setting the patient up. And a lot of times a younger person will go, wait, they did this before I got a chance.
Mm-hmm.
I think they'll all appreciate it if you step up and say, I'm not quite ready yet. Give me a few extra seconds.
Yeah.
Rather than in the middle of the case when it really counts, you're going, I'm not sure if we did this right. And I
Right.
think that was your issue of overconfidence and underconfidence.
Yeah.
Plays a role there too.
Yeah. Interesting. Yeah.
But, well, I thank you for doing this.